Good afternoon, everyone, and thank you for joining us this afternoon for today's presentation on called Raise the Bar on Clinical Communications for Hospitals and Healthcare Systems. And so today we're going to go through we have a few items to kind of cover. We're going to give you a little bit of an overview. So we'll do the housekeeping introduction, which we just did. I'll introduce our speakers, overview of a little background on Everbridge, which I'm sure many of you are familiar with, so we'll spend a little bit of time on that. And really what we want to introduce to everyone today, if you haven't seen it in the past, is CareConverge, which is really Everbridge's clinical communications solution. And so we want to introduce that and then really go into some customer success stories from the field to help you understand different ways that folks are being successful with the solution. And then we'll also go, at the end here, we'll spend a little bit of time on Q&A. Also, during today's presentation, we have a couple polling questions. So when we get to the polling questions, we'll give some instructions about how to respond to that. If you have questions, you can submit those to the questions section in the GoToMeeting pane that you see highlighted there on the screen. Just as a side note, we do record these webinars, and so they'll be available. The webinar actually will be available after today, so if you want to share it with colleagues, etc., we'll be sending an email out with that information for you. And then, as always, you could follow us on Twitter at Everbridge, or even at EB Healthcare, which is our healthcare Twitter handle. So without further ado, let me just introduce. First, I'll introduce myself. My name is Chetwynd. I'm the General Manager of Healthcare Solutions here at Everbridge. And I'm lucky to be joined today by our Chief Medical Officer, Dr. Ranya Habash, and who will also be providing some of that clinical content and some of the customer success stories as we go through today. So let me just start off with a little bit of background about Everbridge, as I know many of you probably have some good experience with our organization. So Everbridge really started off with the understanding after sort of 9/11, how could we help all those first responders communicate on one platform at one time and really impact the outcome of that major incident or major incidents like that. Since that time, we have grown from an organization that really supports that workflow to really a global organization where we're delivering, in 2015, we actually delivered over 1 billion messages across our platform. We have somewhere around 3,000 global customers, and you can see some of the other metrics about our organization, which is really around driving communication, messaging across various scenarios where it's absolutely imperative that the message gets through and teams can activate and respond to those particular messages. So, so that's a little background on sort of where we started. Since that time, as we've grown, we have worked in a number of different marketplaces, but really continue to always strive to be a market leader. And you can see here from Gartner, which is one of the analyst organizations that analyzes, kind of assesses, you know, who are the solutions and vendors in the market who really provide the better solutions based on category. We've consistently maintained ourselves as a leader in that in the category of really critical communications. And you can see some other accolades here that various organizations have provided on us. So that's really our goal, is to be the leader in that market, in the marketplace from a critical communication perspective, and we continue to strive to do that. And how does that apply to healthcare? Well, as I'm sure many of you know, healthcare is one of the areas that we really service, and healthcare has a lot of critical communications that need to happen on a very daily basis. And so it's a very natural fit for Everbridge. We currently support actually just north of 850 healthcare organizations, hospitals, health systems, home health agencies, pretty much you name the type of provider. We're providing support to them today on a daily basis across the country. And really, where do we provide that support? So we work in three primary areas from a healthcare perspective. One is safety and security, and that really builds off of that as we discuss kind of the 9/11 type incident or a hurricane or a chemical spill or any of those kind of major incidents that happen where you really are worried about safety and security of personnel, patients, environment, etc. And we do that across the U.S. and in the healthcare system, again, on a daily basis. Another area where we do a lot of work and has been a growing area for us is really IT operations. And really, that's around critical communication for things such as, let's say the EMR goes down. How do you continue to provide communication once that's down? How do you get your IT teams to respond and get that system back up right away? So it's really around critical IT operations systems and really how to ensure that you keep those systems alive, really to support the organization. And then the last one we have labeled here is emergency department, but really it's really clinical communications and clinical collaboration. And that's really the area we're going to talk about today. And it's just sort of the third piece that we work on in the healthcare space. And again, another area where we're striving to become a leader. So without further ado, I'm going to dive into a little bit of sort of emergency departments, sort of as a setting. We do a lot of work in emergency departments today. As I mentioned, it's really not the only area we work in, but it is one that really illustrates very well how we collaborate with healthcare systems today to really support critical communications. And when you look at emergency departments, I'm sure many of you on the line know, there are a couple of key areas that communication really plays a critical part. The first part is really for your high acuity cases, right? So trauma patients, stroke patients, heart attack, those folks are coming in. You need to activate teams rapidly, have them respond and collaborate around the patient, really converge around that patient to really manage that patient critically. And there are there are a number of measurements that happen here, so door to needle time, door to balloon time. We're going to share some of our stories in a moment about how we've impacted those timings, which really lead, every minute in those situations can have significant impact on downstream costs for those patients and health systems and the providers who are providing that care. The second area where we really focus on from an emergency department perspective is just the issue of overcrowding. And, I'm sure many of you know the majority of emergency departments across the country are over capacity today on a fairly regular basis for a whole host of reasons. And when we look at that, we've been working with folks around things such as ED throughput time and really how can we reduce, minimize that throughput time, which obviously will lead to better patient outcomes as well as increased efficiencies for the ED, less boarding within the ED space, for example, and does lead to some of these downstream metrics such as lowering diversion hours for high acuity cases or even patients leaving without being seen from a crowding perspective, right? So that's another area where critical communications can play a key role, and we'll share some of those stories as well. And because we're so heavily focused, we wanted to just share, we've actually looked at across the industry. We recently conducted a survey of emergency departments across the country to really kind of dig into this communication challenge. And resoundingly back, probably not surprising to those of you on the phone, real-time communication has come back as the key factor for success. And when I say real-time communication, that real-time communication that takes into account that your teams are remote and not necessarily always working in the same physical space, and how do you rapidly coalesce those teams and yet still provide the nearly equivalent of face-to-face communication to be able to assess patients, collaborate with other clinicians, et cetera. As you can see here, 37% of sentinel events, according to the Joint Commission, are caused by communication and assessment failures really around those teams coming together. And then in our survey, we actually asked the question of how many of those, as you think about the handoffs that happen from clinician to clinician, from staff member to staff member, how many of those handoffs really lead to communication errors along the patient's pathway within the ED. And we heard a resounding back that 9 out of 10 of those communication errors do result in, of those handoffs rather, do result in a communication error that could obviously impact patient care and or even just delay care being delivered appropriately. And so actually, we asked a bunch of questions across that survey, and this kind of leads us into our first question for all of you. We have a quick polling question. You want to introduce that, Megan?
Yes, we have, you should be seeing it on your screen right now, but we are asking on a scale of 1 to 5, how much of a problem is getting a response from a specialist. And should, yeah, so, okay, so we have some results coming in right now. Wow, it's pretty even. We really want to try to get to 100% voted, so just answer the question on the screen. All right, it looks like.
Give you a minute to click.
Looks like 3, so like middle of the road. It's coming up a lot. Yeah. All right, great. I'm going to close out the poll. Okay, cool. We can share the results.
So first of all, thank you everyone for taking the moment to vote here. You know, this, as I mentioned, was one of the key questions that we asked in our survey, and it looks like over half of you kind of thought that it's sometimes a problem, basically sort of middle of the road is a problem, and then after that started leaning towards more of a problem. Just to share back, 32% of respondents across the country actually indicated that getting a response from a specialist is a challenge for them, is either always a problem or usually a problem, sort of a 1 or a 2. And that was kind of a common answer that we heard back. And I think really speaks to some of the communication challenges that exist across the emergency department, and particularly with specialists quite often being remote. I think that makes that a tough situation. So again, thanks for participating in the poll. What I'd like to do now is just share a little bit of sort of how Everbridge really works with customers, and give you kind of an example story here of how we've worked with customers using our technology to try and improve those challenges, right? So in our example here, we're working with a stroke patient who's inbound on an ambulance, and basically in our example here, we have EMS notifying the hospital, in this case notifying the hospital via our mobile platform, so directly from the ambulance on the way in, providing a basic summary of the patient as well as the ETA, in this case to the triage nurse in our scenario. That triage nurse is then again on that same platform able to immediately reach out and notify the ED physician who is also working today in the ED to say, hey, we have this inbound patient, you know, if you take a look, let's look at next steps. And really those next steps, the ED physician decides we really should get a call for a neurology consult. On the platform, with a single click, they're able to basically go off and request that consult. And that consult routes over to the on-call neurologist. And you know, just as a background to this, I say that, you know, you want it to work as easily as this, right? In our scenario, that neurologist is not sitting in the ED, as you can probably, many of you can imagine, but it actually is remote to our entire scenario. And we also don't necessarily know who the on-call, quote-unquote, neurologist is. So in the background here across the platform, the solution's looking at schedules, it's looking at escalation paths, so all that's automated so that all the ED physician and the nurse have to do is say, I want the consult, and then all the automation happens to make sure that that we get that neurologist online in a timely fashion to really be able to help manage that patient. Now that neurologist is able to jump right into the conversation with us and basically say, hey, let's get online, let's do a stroke assessment. And in our stroke assessment here, as for many of you who know, that's really a visual assessment, right? So the neurologist really needs eyes on the patient. And so again, on the same platform, he conducts a video assessment of the patient directly on the ambulance, is able to run through the NIHSS stroke scale in this example, and then make the call and verify the CVA, onset time and severity, et cetera, and really then call for the stroke code back with the ED team. Which is going to be our next step, which again happens on the same platform. And now we're going out, we've conducted our assessment, we're now going to activate the team, and you can see here, as again, for those of you who work in the ED know, there's quite a lot of folks who have to really be engaged around this inbound stroke patient, including our lab tech, CT tech, pharmacy. We need our coordinators. We want to notify the HUC about orders, so there's some administrative stuff that has to happen, right? And all that happens across this platform, automated in the background to notify all those folks. From here, the team members respond. I could see those responses. And the physician and the neurologist in this case can actually also receive images directly up from radiology. And so in this case, our radiologist is posting the CT scan up to the solution set. And again, this could be any set of images depending on the type of patient. The neurologist is able to assess those directly here and then make the call about the medication that, in this case, calling for TPA to be administered, which again, we've already notified the pharmacy. We've got our nurse sitting there. The team is ready and is shaving minutes off the time to respond to be able to administer that TPA once the physician makes the call about the stroke. From here, we have that. We can track our door-to-needle time, which is obviously one of our metrics from a hospital perspective. But then also the story doesn't have to stop here, right? So we can actually do the handoff to the intensivist as the next phase. All that history is immediately available to the intensivist. We can notify the admin supervisor of the transfer. And then really lastly, we can actually close out the case. And that now not only creates a summary report of what happened, but also actually that summary information can be shipped off to our stroke supervisor saying, hey, we had a stroke here based on kind of the protocol that we've set in place here. So I know we walked through a lot there, but I wanted to give you kind of one example of really how real-time communication across really a disparate team can shave minutes. And I'm going to turn it over to Dr. Habash, who's going to actually share, we did this in a real-life scenario, and she's going to share some of those results with you.
Hi, everyone. I'm Dr. Ranya Habash. I'm the Chief Medical Officer for Everbridge. And, you know, a lot of the things that Eric was saying, I know it seemed like a deliberately sort of long path to get responses from people and to sort of coordinate people. And that is exactly the point we were showing. Because, you know, going back to that metric, is it hard to get a hold of a specialist? It's not like a specialist, I happen to be an ophthalmologist, are sitting around doing nothing. You know, we're seeing patients, we're running around the hospital, we're doing a million things at once. And when the service or the ED doctor calls our answering service or our front desk, it may be a while before that message is relayed to us and a while before we can call back because we're with another patient at the time. So when you do call back, what happens? You know, everyone who's in the healthcare industry here knows when you call back, you never go directly to the person who called you, right? You sit in a queue, you're on hold, waiting for the nurse to get the chart, waiting for her to locate the doctor, who has also moved on to another room now and is seeing a patient. And the whole process sort of becomes a vicious cycle. So by the time, you know, simple communication can be, you know, by the time you can finally get a hold of someone that you need to get a hold of, you know, you've already wasted a lot of time. And imagine having to activate an entire team and going through that same scenario with everyone on the care team. That's exactly where all the minutes add up and where communication is very key to streamlining the processes within the hospital system. So onto the Mayo Telestroke project, you know, this project sprouted from a statistic I read where 85% of patients who call 911 are actually never admitted to the hospital. What that means is that they really just needed help figuring out what medicine to take or help getting off the toilet or something like that. So they were non-acute events. But what happened when this occurs is that it takes away resources from the patients who really need them. And the stroke patients are a great example of this. In medicine, we say that time is brain, and that means that, you know, every 1 minute that stroke patient is waiting for intervention, they're losing about 1.8 million brain cells. And even 1 or 2 minutes saved can be the difference between a patient walking out of the hospital and being wheeled out of the hospital. And so when you can target those really critical patients and make their processes more streamlined and efficient through better communication, then you're saving lives, saving brain cells, and saving costs for the whole health system. So what happened is I took this idea to Mayo Clinic and got our partners, Apple and Verizon, to join us on this. And the 4 of us banded together to put together a feasibility study. We wanted to see, is it possible to triage patients from the ambulance rather than waiting for the stroke patient to arrive to the ER, then calling the stroke team down to assess them? And it turns out it is feasible. Not only is it feasible, we actually saw some great benefits from it as well. So we showed that the NIH stroke scale was indeed able to be performed in transit, and we saved door-to-needle time. 7.45 minutes may not sound like a lot, but again, multiply that by 1.8 million brain cells, and we've got the number here above. It's 13.4 million neurons saved, and what that means, again, is the difference between a patient walking out of the hospital and being put into a skilled nursing facility and having some major deficits later on in life. And so that bit of time saved meant the world to everyone. And just so you know, the Mayo Clinic already had a really good door-to-needle time. It was about 45 minutes. The national average is way higher than that. It's up around, I think it's 74 minutes. And some other places like Cleveland Clinic have been able to decrease their door-to-needle time by about 53 minutes. But in actuality, what we did here with Mayo Clinic, our door-to-needle time total was about 37 minutes, as you can see here. So, I mean, it was tremendously better than any other place in the country, and the outcomes showed. So because of this, because of the early intervention and treatment and triage, we decreased hospital length of stay and decreased complications for the patient. In one case, we were able to save a patient who had a hemorrhagic CVA, a hemorrhagic stroke, 13 days in the ICU, which adds up to tons of money for the hospital system. We went one step further because the success was so great that then we decided to compare it against the robotic sort of telemedicine unit that Mayo Clinic also had. And it turned out that not only was the robot way more expensive, about 1 million times more expensive, but it also added another 8 minutes to the door-to-needle time. Why do you think it added minutes? It's because it was cumbersome to use. And the neurologist had to go take it out of a closet somewhere, boot it up, get it going, and that whole process just added time to our triage. And so we found that just doing our simple, iPad on the ambulance system with our software on it, we were able to save a lot of costs and improve the quality of care tremendously. I like this line, lives and brain cells saved. We can talk all day about cost savings, but at the end of the day, that's priceless. We can go to the next slide. At this point, we're still talking about telemedicine like it's sort of a novel idea, but it's not anymore. I mean, the incidence or the virtual visits in the U.S. have skyrocketed over the last few years. Now, 72% of hospitals are providing some sort of telemedicine to their patients. And, frankly, if you're not one of those 72%, you're obviously behind the curve. And, we can certainly help you get up and running, but I guess the take-home point here is this is not a new idea. It's not a novel idea. This is tried and proven and successful, and it's just a matter of how you want to implement it within your hospital system. We can go to the next slide. This is one of the, Everbridge is very good about listening to its customers, and I don't particularly like this use case, but I'll begrudgingly share it with you just because it's what the hospital wanted. So this hospital, Renown Health, decided that their responses needed to be a little bit quicker from patients to providers. And so what it wanted to show was that there was better response time for physicians to call back patients. Yeah, thank you very much. That's the slide I was looking at. So they wanted to be able to transfer a patient to, or have a physician call back a patient within about 15 minutes. And with our software, we were able to get the message to the physician and have it escalated to whomever needed to call back that patient and get their response time down to where they wanted to be. They estimated, saving money on answering services at about $121,000 per year, and had better patient care, they said, because the physician was able to respond to the patient that fast. Again, I really like this use case because I don't really know many physicians who can call back their patients during the day within 15 minutes. But, let's just extrapolate that along the pipeline and use that for physician-to-physician callbacks, for instance. Anytime you're being able to circumvent the answering service and the switchboard and looking at the on-call scheduling or the on-call calendar, you're saving valuable time and effort. And then keep in mind that the call then doesn't go to another answering service or another intermediary. The call goes back to whoever called you first. And so it's real-time two-way communication, closed-loop process, and that's going to help everyone across the board. We can go to the next slide. Now this is a very important use case that's near and dear to my heart. So emergency department communication is key. This isn't a pretty example, but if you think about the hospital like a plumbing system or like a sewage system, the emergency department is where there's a lot of backup. And when that happens, it backs up the entire system. And we're talking discharging and patients getting into their beds and being able to be admitted, and patients, getting into the ED to be triaged who need that kind of care. The ambulances being able to even drop off their patients. I mean, this is a sticking point for all hospitals. And that's why CMS has a core measure that said that there's something called an ED throughput time. And if hospitals don't meet this core measure, which happens to be about 175 minutes, then they're docked about 2% of their annual Medicare income, which is very big dollars for every hospital system. So anytime you can help them meet their ED throughput time by getting patients through the ER faster, then you're helping them meet their core measures and making them a lot of money. And by the way, that obviously keeps the staff and the patients much happier too. So we have one system that launched our secure messaging and video for ED team collaboration. And what do you think happened? We were able to decrease 48 minutes off the ED throughput time and help them meet that core measure. So again, just to back up for a second, I'm a specialist, and when a patient presents to the emergency room with an eye injury and the ER doctor needs to get in touch with me, I mean, it can be 20, 25 minutes before I can even get back in touch with him. And because of that, it eats into that ED throughput time tremendously. And again, imagine doing that across the board with every specialty, getting radiology results, getting nursing to come down. Those are the types of things that we can expedite with just better communication. I think it's important also to mention here that it's not just with secure texting. We're also talking about video consultations, like virtual video consultations, the capability of doing video, along with some of the other things we talked about, like on-call scheduling integration, automatic alerts and consults, being triggered and sent out along a path. Those are the types of things that really increase the workflow efficiency of the hospital system. We can go to the next slide. Behavioral health is a very big issue these days with telehealth. I'm sure a lot of you have heard about these types of things. There are so many patients who sort of need care from their own home when they have behavioral health or mental health issues. Center Student Research is one of our partners and one of our customers who's done a really great job with this, where they did pilots at 4 different sites throughout Indiana and Tennessee, and they targeted these Medicaid patients with behavioral issues. They happen to be very high utilizers. They come into the ER or come into the doctor's office about 5 times more often than a regular patient because they have issues like anxiety or depression or some of these other things. And whenever you can decrease their utilization by helping them from home, obviously not only are they doing better, not only are they in better hands and more comfortable, but you're also saving costs for the health system as well. There were some things they did as far as case management goes with remote monitoring, wellness coaching, and they used apps. For instance, apps to gauge mood for the day. So every day the patient would, click on one of the emoji smiley faces to gauge how they were seeing, and that report would go to their doctors, and they would have a history of that built up over time. And so not only were they able to capture that kind of data, but they were able to analyze it and change their practices as a result. They noticed a 39% reduction in the number of emergency room visits, a 53% reduction in the number of inpatient hospital stays. Again, every inpatient hospital day is about $1,300 for the hospital system, $7,500 of patients in the ICU. So every single day that you can save from a patient sitting there, not only is it better for the patient, it's better for the health system, and is able, it's possible then for them to get another patient in that bed and to have better turnover then. So there was a very significant improvement in patient-provider communication, and this was a very successful pilot they did. They're rolling this out nationwide now. We can go to the next slide. Great. You know, we could talk all day about some of the things that we're doing with different customers. Again, you know, we listen to our customers, and you know, everyone has a unique set of issues and different sorts of use cases that they're envisioning. And it's funny because you know, just basic communication can really help them with all of these things. Any different use case, you know, that they can think of, pretty much we can help them with. So, you know, we talked about the Mayo Clinic study. Those results, I should mention, were published, and Mayo Clinic actually presented them at the American Telemedicine Association conference last year, and I presented them at the HIMSS conference just last month. So that was very successful. We have another study going on with Brigham and Women's Hospital. They wanted to decrease ED readmits and you know, readmission rates, which is another CMS core measure, by doing at-home and remote monitoring for their patients. We haven't finished that study yet, and so, but we do know that the early data is very promising. There's a study we also did for concussion protocol, which has become a very big issue recently and publicized in the media. When you can triage a player from the field, for instance, and do a concussion protocol from the field, you're saving so many resources and so much time for that player and for the whole health system as well. So we're helping head helpers, we're helping them do a high school football study where they're able to triage these players from the field. We have a couple of other things going too with some college football teams as well, college universities and their football teams. There are several teleconsult programs for physician-to-physician consultations, and this can be for remote areas that don't have really good specialist coverage, and it could just be as an augment or a supplementation to certain hospital systems that want subspecialists, for instance. So it's very beneficial across the health system. Again, this is a one-touch sort of, think about the software like you use your native applications to talk to your friends and family. This is basically like having iMessage and FaceTime, but it's all HIPAA compliant. So there's no webcams, there's no microphones, there's no heavy equipment set up, there's no hardware really involved because everyone has the hardware in their pocket. It's on any phone or any tablet or any desktop as well. And so because of that, it becomes sort of ubiquitous. There's not a lot of cost involved because it's just software, and it's also very intuitive and easy to use for our patients and physicians and staff. As far as our outpatient telehealth programs go, we have a variety of ambulatory practices that are doing telehealth or offering telehealth for their patients. And I'll elaborate on this a little bit more too. I kind of have an issue with, with companies that are outsourcing their care and getting people who may not be qualified and who don't know the patient to do telehealth visits, even though they're sort of, low acuity visits. I still think that when you're a physician, you sort of owe it to your patient to be able to give them access to telehealth. And they're happier too because now they're seeing their own physician who has their own records and can do the follow-up visits as well. So there's been a lot of stuff in the press lately about how this surge in outsourced telehealth visits from consumer, facing companies has actually increased healthcare utilization costs. And I can see that because, your kid develops a cold, you go online, you get somebody who you think may be a doctor, and they prescribe something to you, but it's not right, it doesn't really fix the problem, and you still have to go to the ER, you still have to go see your pediatrician anyway. And so now you've sort of doubled up on the charges for your health system, whereas had your pediatrician offered that sort of care, you could have gotten much better care, much quicker and much more efficiently, and everyone would have been saved. Does that make sense? Let's go to the next slide.
Yeah. No, that was great. Thank you, Dr. Habash. I think, so the last thing we wanted to just kind of cover, and actually Dr. Habash did a great job kind of highlighting this, is just, what is in this solution that we're talking about, just as background. Really, there's a couple of elements. as Dr. Habash really highlighted, the key is it works basically like your current iMessage type solutions. So, and across that we can do everything from, team collaboration and communication, secure team collaboration and communication, over to telemedicine, teleconsults, which hopefully you saw in some of the examples today. But behind that really sits a number of different things, including we have a care events engine, which really helps us. It's a very configurable engine to drive different protocols. So everything from let's activate for a stroke alert to I think you saw the example where we were actually working on remote patient monitoring of patients in home. And so when we receive an abnormal vital sign, for example, we can escalate that up to a care manager back at a hospital setting or another monitoring setting. So that all sits behind the scenes, as well as our dynamic care team management capability, which includes everything from built-in on-call scheduling, so we know who's on call, we know how to escalate. To Dr. Habash's point, obviously physicians in particular aren't always sitting around waiting for that call to happen. In many cases, many of our customers have multiple folks who might be covering for different scenarios, realizing that someone might be in with a patient, et cetera. And so how do you manage all that automatically? And that's really what that's really based on. And that's all built on our platform that we talked a little bit about earlier, which is really a complete enterprise integrated platform that integrates into your current technologies and is really designed to be what we like to think of as the FEMA equivalent type platform, meaning it's always up, messages get through. We spend, there's a lot of capabilities built in there, including all your basic security things that you might expect, things like being able to wipe devices if information gets lost, protecting PHI. So all the IT kind of and legal requirements that you would have in place are all covered across that platform. So that's really what, we wanted to cover that content today. I think at this point, we're going to take a few questions, and I'll just remind everybody, actually I'll pass it over to Megan for questions. Sorry.
Yeah, great. Thank you guys both so much. That was a great presentation. At this time, we would like to move on to Q&A. As a reminder, you can submit your questions by typing into the questions panel on the GoToWebinar interface. You have to submit it to all panelists. We did have one question that was already submitted before the webinar, and I believe Dr. Habash should answer this one for sure. There is a question about teleconsults and whether or not you can get reimbursed for teleconsults.
Yeah. So again, a very important issue in the health system. We all want to do what's right for our patients and save costs for the health system, but I do believe we should get paid for what we do too. There are 31 states now that have parity laws. And what that means is that private payers, excuse me, private payers are supposed to be reimbursing for telehealth calls, telemedicine calls. And telemedicine has to be, it's defined by the American Telemedicine Association and these guidelines as real-time video. So it can't be that, patient sends you a picture, you make a determination about a rash, and then you can bill for that. It doesn't work that way. You have to make real-time face-to-face contact with the patient via video that's HIPAA compliant. And that's where the guidelines lie. So they're in 31 states. You can do this with private payers. Almost every single state has a Medicaid program that does pay for telehealth consults. Medicare is our last obstacle. They, think that the patient needs to be in a rural location, and there are very few of those that they actually outline on their site. And so they haven't been a very good, they haven't been a good payer at all recently, throughout history, but in terms of telehealth. But, I'm sure there are tons of legislative laws, and they will get up to speed. Right now, it's more for chronic care management and remote locations. But again, the majority of states and the majority of payers will pay for these types of visits.
Excellent. Thank you so much. Next question and final question, unless we get some more submitted, is for Eric. How does your system work with the hospital switchboard?
Yeah, so that's a good question. I know Dr. Habash covered a couple of examples where probably many of you on the line were picturing that's something that we would call down to the call center or the switchboard to kind of activate some of these things. And so we work today with a number of customers where really they're leveraging our software alongside some of their other software to really improve that process from a switchboard perspective. So in the cases I'm thinking of, they continue to run a switchboard where they might get the call to activate the stroke alert, or even something as less urgent like those patient callback examples that you saw earlier. But rather than reach out, for example, in a patient callback where they might have to do a page and then wait for the physician to kind of call the patient, and believe it or not, we have some customers who then actually do a follow-up call to the patient to make sure the patient did the calling. It becomes a closed-loop process where essentially they're notifying the physician gets back in touch with the patient, kind of confirms over the platform that they did that. That closes out the whole experience, which obviously provides better patient care, works well from a physician perspective, and also quite often ties into those HCAP scores and the satisfaction scores that many systems see. So that's one way that we quite often work with operators and call centers today.
Great. And okay, so the last question is, you mentioned a survey that we conducted. Where can we find more information on that survey? Yeah,
so as I mentioned sort of briefly as we went through here, we actually did a survey for those of you who work in the emergency department or around the emergency department. We surveyed about 10% of all the emergency departments in the U.S. to really dig into some of these communication challenges that they see. Everything from errors to, what are their toughest challenges, what works, what workflows have they put in place, what workflows have worked for them, and et cetera. Certainly, if you want to receive that survey, we'll be sending out information after this with the link for the webinar. We can also include a link directly back to that survey for you as well. It's certainly also up on the Everbridge website under our CareConverge area as well. So, and feel free to share that and comment and et cetera. We welcome all feedback. So.
All right, great. I think that was all the questions that we had for today, and I'd like to thank both of our presenters. It was a great presentation. As a reminder, the slides as well as the recording will be sent out to all of you via email within the next coming days. So just watch your inbox. And if you have any questions, please feel free to reach out to our. You can just reply directly to our marketing email. And yeah, and definitely once you leave the webinar, you'll be prompted to fill out a feedback survey. It just helps us, even more fine-tune our presentations and our speakers. So it's a big help. And yeah, and thank you again for showing up today. And this was a great presentation, and we hope to see you online soon.